Good afternoon and welcome to our January 2017 Dementia Dialogue. My name is Heather Mulder and I'm going to be your moderator for today's session. Our January 2017 webinar brings us to a new series of discussions that we're going to have with you this year and a new theme to go along with it. This year we're going to be examining different sentiments and situations requiring solutions for you as a caregiver. We're going to be discussing things like today with emotional changes. We will talk about how to handle difficult driving situations, helping the person feel worthwhile, just a whole variety of different topics that we've received feedback as being issues and challenges that you as caregivers run into pretty regularly. Today's topic is understanding emotional changes in people living with memory loss. A bit of housekeeping before we get started, though. You do have the opportunity to submit text questions to today's presenter by typing your questions into the question pane of the control panel. You can send your questions in at any time during the presentation. I will collect those questions and we'll address them at the end of the program during the question and answer session. At this point, we are unable to take live questions from any of you who are exclusively on the phone. However, we do have contact information provided at the end of the presentation that you can use if you have concerns that need to be addressed. A reminder, our session is being recorded today and will be available on our website within 48 hours of the end of today's broadcast. In addition, a copy of the presentation is available for you to download in the handouts pane of your control panel. Now, it is my pleasure to introduce today's presenter. Lori Nissen is a licensed clinical social worker and is the Family and Community Services Director at Banner Alzheimer's Institute and Banner Sun Health Research Institute. She has spent more than 20 years specializing in leadership and clinical positions, serving the needs of patients and families coping with emotional, cognitive, and behavioral problems. Lori is a distinguished speaker who provides training and education to professionals, patients, and caregivers on topics relating to memory changes, movement disorders, and behavioral health issues. Lori also serves on the Desert Southwest chapter of the Alzheimer's Association Leadership Council. At this point, I'll turn the call over to Lori.
Well, thank you for joining us. Welcome. We are going to explore the idea of understanding emotional changes in people living with memory loss. One of the things I've noticed as a clinical social worker is that often we really focus on the medical component of the disease, of course, the neurological changes that occur with Alzheimer's disease. We've even done a better job, I think, of focusing on some of the behavioral changes that occur through the course of the disease. But really, it seems we focus more on some of the emotional changes that occur with dementia, and so I'm often asked about how the emotional changes and mood changes and affect changes really play into the course of dementia. And I've noticed, too, that as care partners have a better understanding of the emotional changes and the emotional impact of the disease, they tend to have a bit more empathy and understanding, and it can also help reduce the stress and struggles and frustration that sometimes accompanies caregiving. I should say oftentimes, because we know that caregiving is something that many people take a lot of pride in and really are so dedicated, but often do recognize that there often is frustration in the caregiving role. So really what I want to focus on today are some of the common emotional changes in somebody with Alzheimer's disease as the disease progresses. We'll plan to cover emotional changes that might be distinct to even other types of dementia aside from Alzheimer's disease, and really focus more on caregiving and how identification of some of these emotional changes can really give you some insights in how to be more supportive to the person with dementia. Because we know that, dementia can really kind of reduce somebody's level of self-esteem as they're having more and more trouble with everyday tasks. So we'll explore some opportunities on how to really kind of reaffirm the person with dementia, but also really focus on ways that care partners can also take better care of their person and in effect, have better opportunities for self-care. So we know that, the emotion center of the brain, the memory centers of the brain are all contained, and really emotions fluctuate with some of the changes that occur in memory and thinking. Emotions are really a framework, offer us a sensitivity framework, if you will, for really directing our attention, motivating our behavior, affecting our thoughts. They really help us understand what is happening in the environment around us. They help us respond to events and situations and shape the experience for us. So just to give you an idea of some of the functions of the brain, just to give you a snapshot, we're of course looking at areas that, include vision and speech, but of course, inhibition and emotion, along with visual and auditory changes. All of these things are working together to affect the individual's experience. So we know that with Alzheimer's disease and other dementias, because these are progressive neurological brain diseases, they certainly affect the emotional and behavioral changes depending on the area of the brain that is most affected at that time and depending on the progression and phase of the disease. So we've noticed, and we'll talk a little bit about how the emotional changes occur through the progression of Alzheimer's and other dementias. We know that emotions and memories are very closely connected. And as memory changes and memory fades with dementia, the ability to have control over our emotions becomes more limited and becomes more challenging. And so that leads to a lot of emotional changes through the course of the disease. So what are some of these common emotional changes? What do we see in folks with dementia? One of the things that we see that strongly affects somebody's ability to function on a day-to-day basis is apathy. And think about that as really a dampening of emotion. So when feelings of apathy are present, the person who used to be very vivacious, engaged, enjoying celebrations, goes to a grandchild's birthday party, but is quiet, sits in the background, maybe doesn't say much. So families often feel frustrated because they think, well, this person is not interested in the birthday party. They don't care. But really, this is the apathy setting in, where folks withdraw into the background or maybe even decline attending events that they've always enjoyed doing. So apathy affects somebody's ability to really engage, participate, and feel good about activities of daily living. So we see folks who have always been incredibly active now saying no to helping out, losing interest in socializing, and just really retreating, becoming less expressive emotionally and even physically. So we work with patients and families at Banner Alzheimer's Institute all the time, and as a clinical social worker, I hear people say things like, a daughter I spoke with recently who was explaining that her mom, she'd moved in with her mom during the early stage of Alzheimer's disease, and they had a really nice partnership. They shared, chores and activities and fun, and she started noticing that her mom, who was always an astute housekeeper, doesn't want to help with chores, doesn't ask about them, and doesn't even notice when they're being done. So she's just, more indifferent, more removed. And I think it's important for families to understand that this is part of dementia. It's not that the person's being difficult. It's not that they're volitionally trying to pull back. Apathy is an integral part of the emotional change that occurs with dementia. So apathy really deflates somebody's motivation. It pulls away their get up and go. So someone who has been incredibly active, maybe he's worked his entire life. Mr. Jones got up early, exercised, worked a lot of long hours. Now his family's saying, all he does is sit on the sofa. So they're concerned about him, and often there's kind of a level of frustration. Why doesn't he try harder? The person becomes, as I said, less helpful with routine chores, doesn't notice things are being done, and doesn't say, hey, Jody, thank you so much for stepping in and helping out with those tasks. I was too tired to do those. And the social withdrawal and the emotional withdrawal we see that comes with Alzheimer's disease and other dementias, where the person is really having difficulty with conversation. They're easily overstimulated, so that children's birthday party that the grandchild used to be really enjoyable, engaging, exciting for them. But now there's so much going on that they end up sitting back away from the stimulation because they have trouble handling it all. It's too much noise, too many people talking. So the family is starting to really notice and articulate that this person seems a lot more self-involved. They might be less responsive to other people's needs, really lack empathy. So the family believes maybe that the person doesn't care about them. So I worked with a couple, and the gentleman had early-stage Alzheimer's disease, and the care partner was his wife. And the wife noticed more and more that he was withdrawing and very apathetic. And she actually developed cancer. And she was so frustrated when she was trying to express her thoughts, her worries, her fears about what was coming down the line for her with this diagnosis. And she felt like her husband was just totally unresponsive, where in the past he would have been very empathic, very caring, very involved. But because of the dementia, because of the apathy, because of the emotional changes and the cognitive changes, he just wasn't able to be responsive in that way. So a loss of interest in previously enjoyed hobbies is another part of apathy that we often see. And we hear people often, they're not even quite sure what's happening. They might say things like, I always went to bridge, but now I don't even want to go because all those women do is complain. It may really be that the game is too complex, too challenging for the person now that they have a cognitive disorder. They might take away that they're just not enjoying it any longer. If they have a little bit of insight into their memory loss, they might be afraid that other people are judging their performance, or they're afraid that someone will try to correct them during a game that used to be very easy for them and is now complex. So because of these, feelings, they may actually retreat altogether from the activity because they fear being embarrassed or just leave the game knowing that it wasn't enjoyable for them. So apathy can trigger a family's belief that the person is giving in to the disease. It can create a lot of challenges in relationships where family members are saying, yeah, I know he or she has dementia, but, use it or lose it. If he or she would just try harder to engage or continue to attend these activities or keep reading this book, if she would just try harder, everything would be okay. So that sounds logical, but we know that it's not practical and doesn't apply with dementia. Because of cognitive deficits, the person isn't able to change their behavior or work on things or set goals and move forward. And I found, in doing some research on the emotional impact of neurological diseases like Alzheimer's and Parkinson's disease, that particular physician, Dr. Joseph Friedman, says, that actually apathy can act as a protection, even though it functions, it causes family members to feel a sense of frustration, it really, for the person with dementia, can function in place of sadness, worry, or distress. What can be a challenge about apathy exclusively is that it's difficult to treat from a pharmacological perspective. However, being a clinical social worker, I'm always looking at, what can we change in the environment? What can we change in our approach? And I'm pleased to report that with apathy, improving someone's apathy is really more about, providing some structure, providing support, giving more encouragement to keep that person going. And we'll talk more about that as we move forward. So depression, we know and we've learned over time that depression is incredibly common with our adult population. And we know with folks with dementia in particular, depression is quite common. And so, we hear people or we hear family members saying this person is quite tearful, their mood just seems low or down. More often than not, in an older adult population with depression, I hear a lot about mood irritability. This person is just sharp-tongued or cranky rather than sad. So that mood irritability is very consistent and common in depression. It may be that the person is just really having trouble sorting out their emotions, sorting out what is happening to them. Or it may be that if the person has more insight or more awareness of their limitations, depression is really connected to, of course, we know the changes in the brain that trigger depression, but also all the psychosocial factors. So a person who has insight and says, yeah, I'm having memory loss. I'm angry about it. I'm sad about it, because they're having a reaction to having a progressive disease that they're told is only going to get worse. So many people who have dementia may have a depression connected to a despair about the future or feelings of failure. I've always relied on my memory. I've always been able to function very effectively in group settings, and now I feel like a failure. A woman I worked with years ago had been, very active. She worked for the American Red Cross and was very proud of her work, and she was just a very dynamic person who kind of did it all. And when we were in counseling, when she had mild cognitive impairment and then early stage Alzheimer's disease, she shared a lot of these feelings of failure. Lori, she said, I'm having trouble organizing my thoughts just for a Christmas letter that I've always sent out to all my friends, family, and former colleagues. So really feeling some sadness, maybe guilt on how their disease impacts people around them. Maybe even thoughts that life isn't worth living, thinking ahead that the disease is going to progress. And also noticing with memory changes, care partners are stepping in to try to help support that person, but the person may feel that they're really having less control over their own life. So we know that research indicates there's a strong connection between depression and dementia. And actually, people who have late life depression, about 50% have late life depression that's accompanying their cognitive impairment. And we know actually that depression is seen as a risk factor for dementia, particularly in late life. So people who've never had depression as a younger person, as an older adult are having depression, we know that there's a link there, that those might be very early signs or symptoms of dementia. So depression is more treatable than apathy from a pharmacological standpoint. And it's important that we know this because depression can really limit somebody's quality of life. It can make their memory and thinking problems that already exist appear worse. It can make their ability to function day to day dampened. And of course, it amplifies their dependence on the people around them. And we know with dementia that it affects somebody's appetite negatively and impairs their, circadian rhythm, their ability to get a good night's sleep. Depression just further complicates those problems. So we know that medication and intervention is something that our medical providers use often with folks with dementia, because with the depression component, using antidepressants, for example, can have very positive results. So what I've noticed is that in my practice and in my work over time, people with greater insight into their memory loss have greater depression. So as mentioned, they're having a reaction to having this progressive disease. They might even recollect a past relative with the disease. Another woman I worked with who remembered her mother having Alzheimer's disease, and towards the end of her mother's illness, she pictured her, in a nursing center, in a wheelchair with, very limited expression and communication. And so when she was diagnosed with early stage Alzheimer's disease, she was very sad and really focused on, am I going to end up in a nursing home like my mother did? So we also have folks who worry about the genetic component, if they're going to be passing that gene on to the children. Because I have Alzheimer's, now I'm worried that my children and grandchildren will be more vulnerable. People with a lot of insight into their disease worry about the impact or being a burden to their family member. They might voice that if things were to worsen, they wouldn't want to continue on. And so these are the kinds of things that we should take very seriously and seek consultation from the medical provider. So depression is also related to a decline in abilities and someone's reduced independence. So driving, for example, we know that for many of us, driving is really the symbol of independence in America, right? I mean, we know that we can jump in the car and go wherever we want. We have a lot of autonomy. So typically with memory changes, driving stops at some juncture in the disease, usually in early or in the early stage at some point, maybe even moderate. And so this presents lots of stressors for people who can no longer drive. So even if, and this is how we try to help support people, setting up a care partner or setting up transportation services so that the person can still be connected to the community, the depression may be linked to becoming more reliant on other people for help and even for care as the disease progresses. It can be demonstrated in irritability, but also frustration or sadness. And we know that as people age and people with dementia have a lot of pain issues that maybe they can't verbally express because of the dementia. So undiagnosed or even undertreated pain can also be linked to mood changes. Certainly think about if you had a horrible toothache and you weren't able to clearly express to your caregiver or your dentist or your medical provider that you were having this pain, and you weren't being treated for it, your mood would be, declining. Think about your own situation. If you came to work or you came to the caregiver table and your back was hurting, how good is your mood going to be under those circumstances? So I want to touch now upon anxiety, because we know anxiety is often very closely connected to dementia and often very closely tied to depression in our aging population. Often these symptoms are connected to a decline in memory and just that feeling of being lost. Having trouble navigating my environment, navigating the world around me as dementia affects my ability to think clearly, plan ahead, and problem solve. And if I can't do those things, certainly my level of anxiety or nervousness is going to rise. So anxiety means, really being nervous or worried, avoiding situations that cause nervousness. So as I said earlier, I've had folks who have successfully played bridge, but as bridge is becoming more complex, they want to avoid that situation because it creates a lot of anxiety for them. Even situations that used to be very simplistic, like, going out to coffee with 5 or 6 of the person with dementia's friends. That used to be a really enjoyable situation, but now I try to avoid it because my dementia is affecting my ability to follow multiple conversations at one time. So anxiety leads to symptoms of tension or shortness of breath, racing thoughts or fears, worrying about the future. It really even affects somebody's ability to get rest, relaxation, or sleep, which again has a negative impact on memory. So someone's already having trouble thinking properly, and now you throw some anxiety into the mix, and they're not getting enough rest at night because they're worrying about things. And when they're not getting enough rest, then their ability to really think through situations and better manage is increasingly challenged. So we talk a little bit about different types of anxiety that we actually see in folks with dementia. And anticipatory anxiety is one that we hear very commonly. So someone who is really trying very hard to manage their life with dementia. So they worry about things like, oh my goodness, the doctor said I have an appointment, or my husband told me I have an appointment, but I can't for the life of me remember when that is. So constantly worrying about when that appointment is. And then we see a lot of repetitive questioning. So when is that doctor's appointment? Was I supposed to be there? Did I miss it? And so a lot of worries and fears about missing important appointments or events, and asking a lot of repetitive questions around it. Also fear about the disease progression, anticipating what might be an unknown future, and worrying about being more dependent on caregivers and families around them. So separation anxiety is another one that we hear quite a bit expressed by family caregivers. Things like, when I'm out of sight, my person is incredibly nervous. Even when I try to explain to him or her that I'm just going to run an errand or I'm just going to take a shower, that person becomes incredibly anxious when I'm not around. And so we notice that as the person with dementia is forgetting more, they're increasingly reliant on their care partner. The care partner has really become their memory, their comfort, their guide. And when that person is out of sight, it creates a lot of angst for the person with dementia. They feel bewildered. Their anxiety rises. Their Linus blanket or their security blanket is gone. And so I often have care partners or caregivers saying things like, Lori, I can't even go to the washroom because my person is trying to shadow me. And so that often creates a lot of frustration for the caregiver. And the person is not trying to be difficult at all. They're trying to hang on to their guide. And so we coach care partners and caregivers to be gentle about that redirection. Give that person a hug. Give them some verbal reassurance before redirecting them, knowing that their sense of time is impaired. So if you say you're running to the store for an hour might feel like 5 hours to them. And if your spouse, your daughter, your son, your brother, who is with you all the time, leaves for 5 or 6 hours, what feels like 5 or 6 hours, your anxiety is going to rise. Obsessive behavior is another one that we do see. So folks who are hoarding or collecting belongings and doing consultations in the assisted living community, you hear about this a lot where people, are collecting belongings from lunch or from somebody else's room. And this is often just connected to their ability, to their lack of ability to have organized thought and forgetting. Sometimes it's even connected to, past events. People who have experienced economic downturn or famine or war, or remembering those times because the short-term memory is fading, but that long-term memory stays a bit longer. So they may be remembering those experiences from the past and collecting things in an effort to combat or prepare for those kinds of situations. So it's easy to say, why would you don't need 20 crackers. We've got plenty of food for you at every meal. So avoid scolding that person. Allow them to keep certain comfort items even if they're not quite necessary. But subtly make sure that you're removing items that are, excessive or dangerous or even unsafe, like, in assisted living communities, sometimes we're making sure that people aren't hoarding or collecting things like, knives from the dining room. So we want to just subtly remove these items. We don't want to confront the person because they don't know why they're collecting these things, and they can't necessarily change their behavior because of memory loss. So we just want to be subtle and gentle about how we handle these kinds of situations. So when we think about Alzheimer's and other dementias, we're often talking about stages, and we're often kind of breaking things down into 3 stages. So in early Alzheimer's disease, when we think about the emotional changes, we're really looking at someone who's become more dependent on people around them, maybe more fearful. Their ability to make decisions has been impaired. And so often they're becoming more passive and more withdrawn. And as language abilities decline and apathy, that layer of apathy takes over, we're seeing folks who are talking less often, withdrawing more from social situations, even from close family members and friends. As their language flow is more difficult, their ability to organize thoughts, express themselves is more challenging. And remember, too, in early Alzheimer's disease, the person is working so much harder to complete those everyday tasks that used to be so simple or that come so simply or easily to those of us who are cognitively intact. So even though care partners, friends, families are really encouraging the person, they're often becoming less engaged, even when we're really pushing structure and encouraging that person to stay involved in normal activities. So in early Alzheimer's disease, we often hear people with dementia, retreating from activities with some kind of an excuse. And that may be because they're really just having a hard time performing regular activities due to memory changes. Other people may have criticized their performance. And maybe we, as family members, professionals, and caregivers, have forgotten to reset our expectations. So one of the caregivers I worked with in one of our support groups, her husband fell into this category of early Alzheimer's disease. And they had recently moved to our community, into the Phoenix area. And she had wanted her husband to really help her with unpacking. She thought, that seems like a simple activity. So the garage was his domain, and she set him up in the garage, and there were, maybe a dozen boxes. And she gave him instructions about what she wanted him to do, and she came back in an hour, and what was he doing? Nothing. Because even though it seemed like a very simple task to her, there were so many steps that were involved in actually opening these boxes and trying to organize and categorize all of the equipment in his boxes that he just was overwhelmed and didn't do any of it. So we really talked a lot about how they really had to better partner. So maybe they had to open boxes together so that he could stay engaged, but that she could help direct the activity and help support him. We know with early Alzheimer's disease and other dementias, conversation is becoming more difficult to produce and even follow. So giving person multi-step instructions is going to be lost. So the care partner can really assist in this way by shortening or simplifying the activity, reducing the amount of people around and the amount of stimulation around, and really try to focus on greater opportunities for the person to connect. So if that person used to golf 18 holes, that may be overwhelming. Maybe the care partner can think about, could we just golf 9 holes, or maybe just go out and putt as a way to scale down or simplify that activity. So in moderate or middle stage Alzheimer's disease, the person is beginning to withdraw internally. The external world, the environment, people around them, activities are becoming more and more complex and difficult for them to imagine, and even difficult for them to participate in. So we see more of a retreat. That person is becoming more self-contained and more withdrawn, more remote from family members and friends. And as cognitive decline progresses, they're having more and more difficulty with that verbal connection, those conversations. And often there's, just a dampening of that person's affect and their emotion. So we have to work a little bit harder. We know that the person is clearly having more difficulty managing everyday tasks and activities, and they're having less insight and more problems with things like judgment and social and emotional engagement. So we have to work a little bit harder to develop that emotional connection. And we have to really embrace those opportunities in those moments where the person is more present and signs of their old emotional connectedness presents. So I had the pleasure years ago of working with a woman in counseling who was taking care of her husband who had Alzheimer's disease. And she had her own health issues. She had COPD and often used oxygen really to kind of help her function. But they continued to live in an independent living community with caregivers coming in to help her and her husband remain as independent as possible. And she told me a story about how her husband, of course, through the disease and in the moderate stage, had become more and more socially and emotionally withdrawn from her. And they'd had a very emotionally connected and supportive, reciprocally supportive relationship in their marriage through their 70 years of marriage. And she told a story about how they had both woken up in the morning, and he looked over to her and said, "Do you miss me?" And I still get chills when I think about her telling this story, because I think it really was a sign of him being very connected with her at that moment and having some insight into his memory loss in some way, shape, or form, and really noticing and connecting with her. We also hear stories of people who are just, seem very flat, apathetic, maybe depressed at times, but if they're in the right activity that they connect with, or children or grandchildren show up, that person becomes live again and really lights up. So we have to really focus on how to create those moments, and also remember to really embrace and reflect and feel positive about those glimmers when we have the opportunity to observe them. So as the disease progresses, and we have folks who are moving now not from the middle stage, but really more into the advanced stage of dementia, the person is more retreating physically and emotionally, much more limited facial expressions and responses. Verbal connections are very limited. And this presents, challenges for family members to remain emotionally connected to that person. So we want to, many of us are grieving these changes, but we also want to make sure that we're also focusing on ways to strengthen some of the sensory bonds that we can still make with the person with dementia as their memory fades and as verbal skills and communication are impacted. Some of those sensory bonds can still be maintained. So, thinking about bringing around pets, children and grandchildren, staying connected to that person through music, because we know that center of the brain remains more intact for a longer period of time. So even using touch through a hand massage, baking bread so that we can stimulate the senses and old positive memories. Things like, just hugging that person, offering touch, singing together, and even praying together can be ways to strengthen some of the sensory bonds at this point in time in the disease. So let's touch a little bit upon some of the other types of dementia, some of the emotional changes or impacts that we might see. So Lewy body dementia really is our second most common form of dementia, and really I think of it kind of like a hybrid between Alzheimer's disease and Parkinson's disease, in that we see folks who have both the memory change but also have some Parkinsonian-like changes. So from an emotional standpoint, we often see just very rapid changes in their mentation or thinking, sometimes sudden mood changes. And so family members report that they're really feeling challenged with the unpredictability of that person's mood changing, kind of like a roller coaster. And so it's easy to get overwhelmed with the emotional impact and the changes in movement and the changes in memory. But we also can, seize clear moments to enjoy time together. So there was a gentleman and his wife who I've had the pleasure of working with through the course of his disease. He had depression, earlier in his life, and then developed a Lewy body dementia. And he really had a lot of insight into his disease, so that, of course, made his depression worse in some ways. However, because he had more insight, he seemed to do quite well in counseling, just having the opportunity to really express his feelings. And so we met several times, he and his care partner, his wife, and I. And one of the things we really focused on was really focusing on his strengths and staying active in the things that he really enjoyed. So when he was doing well, he really enjoyed travel. So when he was having a good day, for example, he and his wife would jump in the car and do a day trip and, see sites that were really important and enjoyable for him, and really kind of seizing those moments to really enjoy time together. So vascular dementia, of course, folks with vascular dementia, we used to call that multi-infarct dementia. That's when somebody is having changes in their brain as a result of strokes or mini strokes. So you've probably heard and maybe even seen commercials about the pseudobulbar effect, which we see with people with vascular dementia, where they're having episodes where they're quite tearful, crying even, or even laughing, but can't explain, and family members can't think about a stimulus or something that actually triggered that emotion. And also we know that folks who have, vascular dementia have a much higher link of having a depression. And so what's really important in working with these folks is making sure that we're treating depression effectively with a medical consultation with their medical provider, but also as caregivers, providing structure, providing predictable routines, providing activities that the person can enjoy and continue to be successful in. So touching upon frontotemporal dementia, this is where folks often are, because the changes in the brain are affecting that frontal lobe or your filter, if you will, folks tend to be much more disinhibited, more impulsive. We often see a lot of apathy or flatness, or not really appearing to care much about family members around them. And again, it's not that the person doesn't care, it's that apathy component related to the frontotemporal dementia. Sometimes we see just emotional mood lability or changeability, where someone seems very elated or euphoric. Along with that, mood irritability, crankiness, sleep disturbances, and depression and anxiety can really surface. So this is a very, complex type of dementia. So it's really important for families to seek support from their medical provider, but also make sure that they're getting some expert support staff to help them through the process in terms of managing difficult behaviors, managing that memory loss, managing that impulsivity, strategizing on ways to better support this person. And so because this disease is more complex, it's really important to make sure that you're getting the medical piece, but also support staff like nurses and social workers and other people who can really help you manage symptoms from a behavioral perspective of giving you some concrete strategies. So in talking about the emotional changes in somebody with Alzheimer's and other dementias, when should we seek support through our medical providers to better manage symptoms? Well, one is cognitive, because we know that, of course, we can't arrest the disease, but there are medications that can slow the progression of the cognitive changes and often even help in managing some of the emotional and behavioral changes that we see through the progression of the disease. Depression is one that is highly treatable through medication and through support. So we want to make sure that we're reaching out to the medical provider and being clear and in letting them know about symptoms of depression as they present. Mood instability or mood swings is another one we'd want to let the medical provider know and be aware of, as well as, anxiety, that obsessive behavior that we talked about, or the separation anxiety, the anticipatory anxiety. It may be that we can treat some of those symptoms pharmacologically while we really focus more on, shifting our strategies as caregivers. Also letting your medical provider know about any suspected changes in sleep patterns and about pain, even if you're not clear if there's pain, but you suspect it just by noticing changes in your person's daily interactions or even facial expressions, or times a day that they seem more irritable, maybe when they first wake up in the morning and you're thinking, I wonder if there's some arthritis setting in. So letting your medical provider know about those changes so he or she can help support in that area. So along with medications, of course, we really want to look at ways to better support, people with dementia and their families. In the early memory loss phase, if the person has insight, they may benefit from, an early stage support group. Some programs, in fact, we have a support group at our Banner Sun Health Research Institute in collaboration with the Alzheimer's Association that actually separates folks. So we have care partners in one group who are sharing their thoughts and feelings, successes and struggles, and then we have the person with early stage memory loss in the group in the next room who are really sharing their own struggles. So it allows for people to be more candid in sharing some of their frustrations or struggles, and there's less risk or worry about them hurting their care partner. So in our groups, we have people in early memory loss who are really candidly sharing thoughts and feelings about not being able to drive, or not being able to participate in some of the activities that they used to enjoy. And so they have that open forum to express those feelings, and also with the help of the facilitator, really look at ways for them to continue to stay active and engaged in other ways. So in early stage, if you have someone who is, has some insight into their memory loss, you would suggest, an early stage support group that it could be beneficial for them. Of course, if they don't have as much insight or aren't as aware of their memory loss or just don't want to participate, we certainly wouldn't want to push or force that person. So our goal in intervention is really to provide structure and activities that are going to allow that person to stay active with their current abilities, redefining our expectations, and focus on the right time of day, keeping the focus on the things that that person can do successfully, and create a sense of purpose, because we know as memory fades, some of the person's sadness or emotional change may be feeling connected to not being able to engage in the activities they once did, but still wanting to engage in activities. Feel a sense of purpose that can help them increase their self-esteem and sense of value, and really supports positive emotions, positive moments of being engaged in activities and structure that makes that person feel good. So we want to really engage that person's senses, improve interaction with things like children or animals, activities that really focus more on their long-term memory, old photos, music, stories, mementos. Really encourage, and we do have to strongly encourage. We don't want to force people, but if we ask somebody a yes or no question, would you like to go out and take a walk with me, because of that apathy and potential depression, we're going to hear a no. So we have to rephrase the things we say to get people more engaged in things like exercise, even on a very small scale, designed to align with that person's ability and their stamina, can really help mediate depression, regulate mood, and reduce anxiety and agitation, which may be pent-up energy, if you will. But if we take a long walk, that might help to reduce some of those feelings. So activity structure is critical, but most of us aren't activity directors. So we have to look to other people to support the need for structure and engagement, which in turn helps support better emotional stability, if you will. So looking to friends and extended family members. So it may be that that person can no longer attend the bridge game, but can you drop that person off with their friends to, enjoy the lunch afterwards? Looking to extended family members who are saying things like, how can I help you? Well, it would be great if you could come and pick up my dad and take him to that music program you're planning to go to at the rec center or at the church or synagogue, for example. So looking to outside life enrichment activities, whether they're at rec centers or adult day programming, life enrichment opportunities, something that we, at Banner Alzheimer's Institute, partner with a lot of life enrichment programs in our community to help people who have memory loss not become so isolated, for them and their care partners to attend a music program or an art program designed to help support and engage people with memory loss and their care partners. So an ounce of persuasion. So knowing that anxiety about activities and the automatic response from somebody with dementia is to want to withdraw or retreat. Avoid prenouncing activities. Refrain that you would like to get outdoors, go for a walk, etc. That you would really like him or her to accompany you. Avoiding yes or no questions. Using just a very gentle but more directive approach. So things to think about. These are things that people have said over time in some of our groups. I have memory loss, but I'm trying as hard as I can. I wish my person would understand I'm not trying to be difficult. I don't want to be a burden. These are things for us to think about as we're trying to be empathic to the person with memory loss who's also experiencing emotional changes. So the person often wants to please their spouse and try harder, but understand that the person might not have the energy or ability to organize. They might agree to make a change, but then forget later because of short-term memory loss. Recognize that dementia and mood changes ability really interfere with somebody's ability to take action and change their behavior. And of course, we want to validate you as care partners and caregivers, that you're grappling with the ever-changing responsibilities and that there's an emotional impact on you as your role of care partner shifts into caretaker. And so we really have to push back as family members so that we don't retreat and become socially isolated. Other feelings and thoughts that caregivers express, about feeling stressed, feeling angry, frustrated. So remembering to acknowledge that this is a disease, that the person loves and appreciates you, even if they can't verbally express it or don't verbally express it to you. So avoid nagging. It's only going to increase anger. Continue to work at that connection. Work to stay positive, as a person with dementia will mirror your mood. Implement small bites of relaxation for yourself, knowing that big bites are harder to accommodate. Use praise, encouragement, and focus on those moments that are humorous and funny to lighten up the mood. Getting support for yourself, of course, is critical, and respite is required. So arrange to take breaks from caregiving. Get your person active in a life enrichment or adult day program so that that person is engaged and feeling good about themselves, and you're getting breaks from caregiving so that you can recharge as well. So the motto is really ask for help and accept help. So thank you so much for allowing me to give you a little insight into the emotional aspect of Alzheimer's and other dementias. I'm just going to check in with my colleagues to see if there have been some questions that have been submitted, as we have just a couple minutes left.
Yes, thank you, Lori, for this unique look at dementia. I think, as you mentioned early in the program, this is an angle that we don't really focus on very much. Now, we did have a few questions come in, and as you mentioned, there's just a few minutes left, so I'm going to ask you to speak briefly to them. We had one caregiver who was asking about sleep, which I know can be a symptom of Alzheimer's and dementia as the disease progresses, but it can also be a symptom of these emotional changes. So we have a care provider saying that their person is sleeping close to 12 hours a day.
That's a great question, because we know that the circadian rhythm or biological clock changes with dementia, so sleep is really impacted. The person's ability to get good sleep early in the disease, and then, as you're saying, that hypersomnia or sleeping all the time is something we see as the disease progresses. So I would definitely talk with the medical provider about it, but also ask yourself, is this person have enough structured activity? Are they bored? If we're out enjoying a program, are they more awake and alert? If we're getting out to activities, are we making sure to provide rest periods, before and after activities? Because you're right, as people are working so much harder to think and process, the fatigue level increases significantly. So I think it's a fine balance of providing activity and rest, but if you're having someone who's sleeping all the time, think about things like structure and also seeking support or evaluation from the medical provider to make sure that there isn't some kind of other condition that's going on that is making the person more fatigued.
Great, thank you. In the interest of time, it is 1 o'clock now, so I'm going to go ahead and wrap up the dialogue for today. Any of you who have already submitted questions, please know we will follow up and respond over email to those to make sure that you get them addressed. As reminders, this session was recorded and it will be posted on our website within 48 hours after the end of the webinar today. As soon as we end as well, you will receive an evaluation, and please do take a few moments to let us know what you thought of today's presentation, and if there are any other topics that you would like addressed in the future. We create these for you to try to meet your needs, so we need to know what the best topics will be for you. I invite you to join us next month on February 15th, where we look at a situation requiring a solution. This one is all about family conflict. So I, again, thank you for joining our Dementia Dialogue this afternoon, where we bring the dementia education to you.